I'd like to thank Professor Inam, Dr. Chauhan, Dr. Charania for inviting me to take part in this neuro-oncology webinar series from PASNO. I consider this as a great honor, and it's certainly a pleasure for me to participate. And today I will be discussing the evolving molecular classification of embryonal tumors of the central nervous system. As we know, the WHO 2021 classification, popularly referred to as WHO CNS5, has been built on the prior 2016 classification after incorporating all the recommendations of the CE impact updates. So this classification has advanced the role of molecular diagnostics in CNS tumor classification. Nevertheless, it is deeply rooted to the established approaches of tumor characterization, such as histology and immunohistochemistry, and therefore it presents a hybrid taxonomy. Now, this table gives you an overview as to how tumors are classified in WHO CNS5. As you can see here, there are 12 tumor groups. Each of them have several tumor types. I have not listed them. Many of them are genetically defined. But what I'm going to focus on today is the group of embryonal tumors that includes medulloblastoma and other CNS embryonal tumors. The classification of CNS embryonal tumors has evolved over a period of time. Up to the WHO 2007 classification, these were only histologically defined and included three major tumor entities: medulloblastoma with all the histological subtypes, the atypical teratoid rhabdoid tumor, and the CNS peanuts that included ependymoblastoma, medulloepithelioma, CNS neuroblastoma, as well as ganglioneuroblastoma. Subsequently, in WHO 2016 classification, they were divided into two groups, the genetically defined and the histologically defined. And all of these embryonal tumors they had both genetically defined and histologically defined entities, except for these three tumors, which were only histologically defined. And at this point of time, the term peanut was completely removed. Now we have moved on to the 2021 classification. And as you can see here, this classification is much simplified when compared to the prior classification. And there is inclusion of newly recognized tumor types as well. I'll begin with medulloblastoma, which is the most common of all the CNS embryonal tumors. We consider medulloblastoma as an unitary disease wherein there are surface variations that occur within a single underlying disease process, as evidenced by its histological subtypes and the molecular subgroups. Although medulloblastomas can occur at any age, we know that it is more common in the children, and the second most common CNS malignant tumor of childhood following pediatric type high-grade gliomas, accounting for approximately 20% of all the intracranial neoplasms in this age group. Median patient age at diagnosis is about 9 years, although there are peaks in incidence between 3 and 7 years, and we do know that medulloblastoma can occur in the setting of several genetic tumor syndrome. Now, this flowchart gives you the timelines for the key discoveries in medulloblastoma. With respect to surgery and histopathology, it was in the year 1926 when the initial description of medulloblastoma, including clinical histopathological characteristics, was put forth by Cushing and Bailey. And in 1969, Chang described the metastatic staging of medulloblastoma. With respect to adjuvant therapy, in the year 1959, a landmark study demonstrated that the addition of craniospinal irradiation improved the 3-year survival rates of these patients to about 60%. And in the 1970s, there were randomized trials that demonstrated the survival advantage of addition of the cytotoxic chemotherapy regimens to these patients. With respect to molecular genetics, it was in the 2000s that studies identified the recurring mutations in the SHH and the Wnt signaling pathway genes. And following this, over a period of decades, several high-throughput genomic and epigenomic studies were carried out. And in the year 2011 to 2012, the consensus classification with the 4 molecular subgroups of medulloblastoma was established. Now we've come a long way after that, and in the past decades, we have seen further advancements in the molecular genetics and the understanding of the biology of these tumors, as well as with adjuvant therapy, including the proton beam therapy, as well as the targeted therapies. Medulloblastoma is a tumor of the cerebellum, as we all know, and the large majority arise in the midline vermis, although a small proportion are in the cerebellar hemisphere. These are very infiltrative tumors. As you can see here, they project into the 4th ventricular cavity, and craniospinal metastasis is seen in about 50% of these patients, with about 30% coming to the clinic with upfront metastatic disease. So as I mentioned, up to the WHO 2007 classification, medulloblastoma was histologically defined and included these subtypes: the classic, the desmoplastic nodular, medulloblastoma with extensive nodularity, large cell, and the anaplastic. Classic medulloblastoma is the most common. These tumors occur in the midline posterior fossa involving the fourth ventricle. And histologically, it's a very cellular tumor composed of these densely packed, poorly differentiated, small, round embryonal cells that exhibit a very high nuclear cytoplasmic ratio, a brisk mitosis, and homocyte rosettes or neuroblastic rosettes that you're seeing here are seen in less than 20% of the cases. Desmoplastic nodular medulloblastomas are seen mainly in the cerebellar hemispheres laterally. And these tumors are characterized by these nodular pale neurocytic islands that are reticulin poor, surrounded by reticulin rich zones that are filled with these poorly differentiated cells. And medulloblastoma with extensive nodularity is an exaggerated desmoplastic nodular medulloblastoma, wherein all these lobules or the nodules are markedly expanded. And these tumors occur in very young children, midline posterior fossa, and they're so nodular that they impart this bunch of grape-like appearance on radio imaging. Large cell and anaplastic have been now combined, and these tumors are very cellular, composed of large cells that have an extensive nuclear pleomorphism, nuclear molding, as you can see here, and cell-to-cell wrapping, what we call as cell cannibalism, is seen in the majority of these tumors. And mitosis, apoptosis is very brisk here. They're seen in clusters, including formation of such apoptotic lakes. And melanotic and myogenic are considered as variants of medulloblastoma. Now, if you look at the treatment of these children, it involves neurosurgical resection, radiotherapy that is usually restricted to patients above the age of 3 years, and cytotoxic chemotherapy, as all of us know. And with this, the 5-year survival rate hovers around 75%, although most of the survivors suffer from serious cognitive, endocrine, and psychosocial sequelae, although this is reduced with newer modalities of treatment like the proton beam therapy. Therefore, a significant effort has gone and dedicated to stratifying medulloblastoma patients based on not only clinical, radiological, and histopathological features, but also on the molecular parameters, with an overall goal of either de-escalating the therapy or intensifying the treatment. Now, the initial clinical risk stratification of pediatric medulloblastoma, as we know, was based on the Chang criteria, which is a 2-tier stratification system. Based on the extent of the tumor that ranges from T1 to T4 and extent of metastasis that ranges from M0 to M4. And we do know that the M0 stage is associated with a better prognosis when compared to the M+ stage. Subsequently, these children were clinically risk stratified into high risk and the average risk group. High risk patients are those who are below the age of 3 years or who have undergone subtotal resection or have evidence of metastatic disease, and the others are the average risk patients. And whilst the 5-year survival rates of the average risk patients has been shown to be above 80%, it is below 70% in the high risk group. Subsequently, other prognostic parameters were looked for in medulloblastoma, and initially it was histopathology. And these are some studies that correlated the histopathological subtypes with prognosis in medulloblastoma, starting with the early study by Professor Gian Gasparo and colleagues, and McManamy et al., Cool et al., and our own study. And in all these studies, the desmoplastic nodular has been found to be associated with the best prognosis, large cell anaplastic with the worst, with the classic coming in between. However, the limitation of these studies were that they did not reflect on the prognostic differences that existed within the same histological subtype, and therefore it initiated the search for other molecular parameters that could predict the clinical outcome. Now, the understanding of genetic alterations and aberrant signaling pathways in medulloblastomas came about with studies that were carried out on 2 inherited tumor syndromes, the Gorlin syndrome or the nevoid basal cell carcinoma syndrome, and the Turcot syndrome, in which medulloblastoma is one of the tumor types. We do know that Gorlin's occurs as a result of the germline mutation of the tumor suppressor gene known as the patch gene that is involved in a pathway known as the sonic hedgehog or the SHH pathway, and the Turcot's occurs as a result of the germline mutation of another gene known as the APC gene that is involved in the Wnt signaling pathway. And both these pathways are actually developmental cascades, and they have a crucial function during normal brain development, particularly the cerebellar development. And dysregulation in these pathways have been shown to lead on to medulloblastoma tumorigenesis. Now, understanding of these genetic alterations and aberrant signaling pathways led to several high-throughput integrative genomic and epigenomic studies over the next decade, resulting in the identification of distinct molecular subgroups of medulloblastoma. However, there were inconsistencies in the number of molecular subgroups that were identified. And to make matters worse, each research group assigned their own nomenclature to the subgroups, causing a lot of confusion. Now, this table summarizes all the studies that have been carried out for molecular subgrouping of medulloblastoma using various platforms such as the gene expression profiling, transcriptome profiling, microRNA profiling, or even the DNA methylation profiling. And while some of the research groups identified 4 molecular subgroups, some identified 5 molecular subgroups, and still others identified 6 molecular subgroups, and they had assigned their own nomenclatures to these subgroups. The most significant of all these is the study by Northcott and colleagues from Sick Kids, Toronto, who carried out transcriptome profiling on about 103 medulloblastoma samples. And by this, they were able to clearly identify 4 distinct molecular subgroups, which they designated as the WNT, the SHH, the group C, and the group D. Now, these authors went a step further and carried out immunohistochemistry validation for the most robust marker in each of these subgroups on retrospective formalin fixed and paraffin embedded tissues. Subsequently, they came up with a signature from this group itself, a 22 medulloblastoma subgroup specific signature, and this they called as the code set, and they were validated this also on the retrospective FFPE tissues using a technique known as the nanostring encounter technology. And even with this minimal classifier, they were able to identify the 4 molecular subgroups. And so they proposed that this is a rapid, reliable, and reproducible method for molecular subgrouping of medulloblastoma using the FFPE samples. And this is highly suited for the future medulloblastoma clinical trials. Now, these are some studies from our country, from Dr. Jalali's group, where they have carried out gene expression profiling as well as microRNA profiling on a large number of medulloblastoma samples. And with this, they were also able to confirm the 4 molecular subgroups. Now, one of the hallmarks of the study was that they were able to identify a distinctive microRNA signature that was specific to the Wnt signaling pathway. And more interestingly, they were able to derive a signature from this, a signature that was composed of 12 protein coding genes and 9 microRNAs, and they could validate this with a very simple quantitative PCR technique. And with this, they were able to segregate the 4 molecular subgroup, and they proposed that this could be used for routine clinical purposes. Now, Schwalbe-Howitstadt's groups, they carried out DNA methylation profiling for the molecular subgrouping of medulloblastoma. So what we have basically seen is that there have been variations in the number, the composition, and the nature of the molecular subgroups amongst all these studies. And in view of this, the researchers themselves brought about a consensus conference, which was held in Boston in the year 2010, and where a meta-analysis of all the molecular and clinical data of nearly 550 medulloblastoma samples from 7 independent studies were carried out. And from this evolved the 4 distinct consensus molecular subgroups of medulloblastoma that is currently prevailing, that is the WNT, the SHH, the group 3, which was earlier known as the group C, the group 4, earlier known as the group T. And these were shown to differ in their demographics, their tumor histology, their genetic alterations, as well as their clinical outcome. However, we know that it's immunohistochemistry that can be applied in majority of the laboratories and the centers throughout the globe, and IHC-based subclassification is something that we would look forward to. Ellison and colleagues were amongst the first proponents of such a classification, using a set of 4 commercially available antibodies against the beta-catenin, GAB1, YAP1, and filamin A. And with this, they were able to segregate medulloblastoma into 3 subgroups, the WNT, the SHH, and the non-WNT, non-SHH. And this was validated in several studies, including our own studies. And these 3 IHC markers have now been included in the WHO classification for molecular subgrouping into 3 molecular subgroups for medulloblastoma, both in 2016 and 2021 classification. WNT tumors are actually classic in morphology. They're beta-catenin positive. This is a nuclear positivity. One needs to see nuclear positivity to call it positive. It's YAP1 positive and GAB1 is negative. SHH tumors are usually desmoplastic nodular. The beta-catenin negative, you can see that the nuclei are negative here, only cytoplasm is positive. It's YAP1 positive and GAB1 positive, and the non-WNT, non-SHH are negative for all these markers. And another new developmental marker that has been now introduced by WHO 2021 is the OTX2, which is strongly positive in WNT and the non-WNT, non-SHH, but negative in the SHH. And this is a good marker to identify the SHH group of tumors. Now, subsequently, the role of TP53 was studied in medulloblastoma, and it was shown to be associated with a worse outcome, particularly in the SHH-activated tumors. And so these tumors were then divided into two groups, the TP53 mutant, the TP53 wild type, in both the classifications. And a diffuse strong nuclear immunopositivity for the P53 protein is now considered as an IHC surrogate for the TP53 mutation in medulloblastoma. So the classification of medulloblastoma has evolved over a period of time. Initially, it was only histologically defined. In WHO 2016, it was genetically defined, it was histologically defined, and there was this not otherwise specified group as well. But now in the 2021 classification, it is much simplified and includes medulloblastoma, Wnt activated, SHH activated, and P53 wild type, SHH activated, and TP53 mutant, non-Wnt, non-SHH, and medulloblastoma histologically defined, which is a single chapter where all these subtypes are described as histological variants. Now, if you look at the characteristics of medulloblastoma molecular subgroups, you can see that the Wnt activated tumors account for only 10% of medulloblastomas. They're seen mainly in the childhood, predominantly have a classic morphology, and they show monosomic chromosome 6 or the CTNNB1 mutation. SHH activated and TP53 wild type tumors account for 20% of medulloblastomas. They're seen in infancy and the adulthood, sometimes even in the adolescence, and they have the desmoplastic nodular histology and show patched 1 deletions. SHH activated TP53 mutant tumors are rare. They account for only 10% of medulloblastomas. These are childhood tumors, and histologically they are not desmoplastic or nodular. They have the large cell anaplastic histology, and apart from the TP53 mutation, they also harbor the NMYC amplification. Now, non-Wnt, non-SHH is the largest group. In this, the group 3 accounts for about 25% of all the medulloblastomas. These tumors are seen in infancy and the childhood. They have a classic morphology, and they show both c-MYC and NMYC amplification. And the group 4 account for about 35% of medulloblastoma. They are seen across all ages. This is the largest group. They usually have a classic morphology, and they show NMYC amplification. So carrying out FISH for c-MYC and NMYC is very useful to segregate non-Wnt, non-SHH into group 3 and group 4 on a routine basis. Now, there are several radio imaging studies that have tried to correlate medulloblastoma molecular subgroups with the imaging patterns, and these studies have shown that the Wnt tumors are located mainly laterally in the CP angle, and they have a very leaky blood-brain barrier, and therefore they are brilliantly enhancing tumors. SHH activated tumors are located in the hemispheres, and on MRS, they either have a nil or a low taurine peak and a low creatinine. The group 3 and the group 4, both of them are in the midline, and both of them show a taurine peak as well as a high creatinine. Now, whilst the group 3 shows strong enhancement pattern and typically ill-defined margins, the group 4 shows a poor enhancement or absent enhancement with typically well-defined margins. And we do know that prognostically, the Wnt tumors are associated with the best prognosis. Among the SHH, the P53 mutant is associated with poor prognosis, wild type with intermediate prognosis. And among the non-Wnt, non-SHH, the group 3 is associated with a poor outcome, whereas the group 4 with an intermediate outcome. But mind you, it is not just the molecular subgrouping that is important for prognosis. Histopathology also plays a very important role. For example, if medulloblastoma is Wnt activated, it should have a classic histology to be a low-risk tumor. And if it is a SHH activated TP53 mutant tumor, it should be large cell anaplastic to be a high-risk tumor. And if it is SHH activated TP53 wild type, it should be either desmoplastic nodular or an MBEN histology to be a low-risk tumor. If it has any other histological features, then the tumor is of uncertain clinicopathological significance. That's the importance of both histology as well as the molecular subgrouping. So this is some of the Indian data on medulloblastoma molecular subgrouping carried out from 3 major centers, Tata Memorial Hospital, AIIMS, as well as NIMHANS. And all the 3 groups have shown that the Wnt tumors are associated with the best prognosis and non-Wnt, non-SHH with the worst clinical outcome. So to summarize the clinical implication of the molecular subgrouping, we now know that there are 4 consensus molecular subgroups, the Wnt, the SHH, group 3, and the group 4. And as a direct consequence, clinical protocols have now adopted molecular subgrouping strategies, not only for routine diagnosis, treatment stratification, prognostication, but also for patient selection for targeted therapies. And I'm sure all of you are very familiar with this table, which correlates the molecular subgroups with the risk stratification in medulloblastoma, as you can see here. Wind tumors, particularly those below the age of 16 years, are low-risk tumors. Standard risk include the SHH-activated tumors, which are TP53 wild type without NMIC amplification and non-metastatic, or the group 3 without CMIC amplification, non-metastatic, and the non-metastatic group 4. And high risk includes the SHH-activated TP53 wild type that are metastatic, or the metastatic group 4. And the very high risk tumors are the SHH-activated TP53 mutant tumors, whether metastatic or not metastatic, as well as the metastatic group 3. And of course, there is the unknown group as well. And we do know that the therapeutic regimens is now being tailored to each of these risk stratified groups. Now, since these medulloblastoma molecular subgroups are enriched for specific genetic alterations and they show a very distinct epigenomic and transcription profile, it is suspected that these molecular subgroups have distinct cellular origins or developmental lineages. And there are several studies which have explored this, and most of them are experimental studies. And in this study on mouse model, the authors proposed that the Wind tumors probably arise from the lower rhombic lip progenitor cells in the brainstem, which are enriched for these developmental markers. The SHH from the early granular neurons from the from the external granular layer. The group 4 from the upper rhombic lip progenitors during cerebellar morphogenesis. And the origin of group 3 is not very clear. Probably they arise from the nestin positive early progenitors in the periventricular zone, or they could even be non-cerebellar in origin. So that was as far as the molecular subgrouping of medulloblastoma is concerned. But now we know that there are further molecular subgroups within the existing subgroups. And all these data has come because of additional molecular characterization that has been carried out on medulloblastoma and has generated a wealth of multidimensional omics data, as a result of which the molecular classification of medulloblastoma has evolved beyond the 4 consensus molecular subgroup to include the additional subdivisions. And in WHO CNS5, these additional subdivisions are now called as molecular subgroups. And the earlier ones, which were earlier molecular subgroups, the Wind, the SHH, non-Wind, non-SHH, are referred to as the molecular groups. And DNA methylation profiling has emerged as a platform of choice for further medulloblastoma subgrouping. Now, the first of these studies in this direction was in the year 2017, carried out by Cavalli and colleagues, who analyzed about 763 primary medulloblastoma samples, which were already profiled, both gene expression and DNA methylation array, and the raw data was available. They analyzed the raw data using an AI-based bioinformatic approach known as the similarity network fusion approach, and they were able to identify 12 molecular subgroups, which at that time they designated as subtypes, 2 in the Wind, 4 in the SHH, and 3 each in the group 3 and the group 4, and these were clinically and biologically relevant. Subsequently, there were 3 other independent studies who used this combined DNA methylation profiling and gene expression data, again to investigate the additional substructure within the molecular subgroups, and they analyzed this data using other AI-based bioinformatic tools, and they did confirm these molecular subgroups of medulloblastoma. So Wind subtypes included the Wind alpha and the Wind beta. SHH included SHH alpha, beta, gamma, and the delta. Group 3 and 4 included the alpha, beta, and the gamma. And these were shown to differ in their demographics, their clinical profile, their histology, as well as their molecular parameters. Now, subsequently, Northcott and colleagues analyzed the DNA methylation profiling data that was available in group 3 and the group 4 tumors using different bioinformatic tools. They applied what is known as the T-distributed stochastic neighbor embedding technique, and they were able to identify 8 subgroups belonging to the group 3 and the group 4. Now, subsequently, in order to confirm this, about the DNA methylation profiling raw data from 3 studies, Northcott study, Schwalbe study, and Cavalli study, all of them were combined, and they were reanalyzed using the same bioinformatic tool, and the 8 subtypes of the group 3 and the group 4 were combined, where they were confirmed. And whilst the subtypes 2, 3, and 4, they were shown to conform to group 3, 6, 7, and 8 conform to group 4, and 1 and 5 were belonging to both group 3 and the group 4. And they were shown to differ distinctly in their clinical as well as their demographic features as well as their molecular parameters. Now, all these subgroups have now entered into the WHO CNS5, and the Wnt, SHH, non-Wnt, non-SHH are now the molecular groups, and these are the subgroups. Wnt has Wnt alpha, Wnt beta. SHH has SHH 1, 2, 3, 4. There is redesignation of these subgroups, and 3 is the one that is TP53 mutant. And non-Wnt, non-SHH of both these groups have 8 subgroups, subgroup 1 to 8, and as I already mentioned, whilst the subgroup 2, 3, and 4 conform to group 3, 6, 7, and 8 conform to group 4, and 1 and 5 are shared between group 3 and group 4. However, these molecular subgroups are not listed in the classification. They're only described under the header of diagnostic molecular pathology in each of these chapters, but probably in the next classification, many of them will find their way and become codified new tumor types. Now, the redesignation of SHH activated tumors happened in WHO CNS5, and they're now, these subgroups are now designated as SHH 1 to SHH 4, corresponding to beta, gamma, alpha, and delta. And they are, show distinct differences in their demographics, their clinical features, as well as their molecular parameters. For example, the SHH2 usually occurs in infants. They're enriched for this MBEN histology, and they have a very balanced genome associated with a favorable prognosis. SHH3 tumors occur in the children or in the adolescents. They usually have a large cell anaplastic morphology, and apart from the TP53 mutation, they can harbor the NMYC amplification associated with a poor outcome. And all these molecular subgroups as well as the subgroups are seen to be clustering distinctly different on the DNA methylation profiling atlas, telling us that these are definitely distinctly different tumors. But what are the clinical implications of this further molecular subgrouping? Because there is concern among many treating oncologists that the number of divisions far outpaces the ability to provide subgroup specific care. However, what we have seen earlier is that the molecular grouping has already demonstrated its ability for accurate diagnosis, prognosis, and treatment stratification, and subgrouping will probably enhance this even further. For example, subgrouping of medulloblastoma in very young children is anticipated to rapidly lead to new clinical trials in view of toxicities of the CSI as well as the chemotherapy. And moreover, if targeted therapies have to be successful, then it is imperative that these agents be given to the appropriate populations. Now, with that, I'll move on to the other CNS embryonal tumors that includes atypical teratoid rhabdoid tumor, or the ATRT, embryonal tumor with multi-layered rosettes, or ETMR, CNS neuroblastoma, FOXR2 activated, CNS tumor with BCOR internal tandem duplication, and the cribriform neuroepithelial tumor, or CRINET. These are the 3 newly recognized tumor types in WHO CNS5, CRINET being a provisional tumor type. I'll start with a case illustration. This is one of our cases, a 2-year-old child who presented with a posterior fossa mass, and you can see that there is a large solid cystic heterogeneously enhancing mass in the right CP angle. This was biopsied, and histologically it was a very cellular tumor, and you can see that the cells are arranged in the sheeting pattern, and there are areas of necrosis within the tumor. And interestingly, there were several patterns that were there within this tumor. Focal areas had these clusters of rhabdoid cells. Other areas had primitive neuronal cells, very high nucleocytoplasmic ratio. Still other areas had spindled out cells having a sarcomatous appearance, and few areas even had an epithelial appearance with these acinar structures as well as papilloid fragments. By IHC, the tumor cells were diffusely positive for Y-mentin, which is a mesenchymal marker, very focally for epithelial membrane antigen, focally for glial fibrillary acidic protein and smooth muscle actin. And although there were these groups of rhabdoid cells, it was totally negative for Desmin, and the proliferation index was very high. This was mitotically very active. And in view of this varied histological pattern and the polyphenotypic immunoprofile, we made a provisional diagnosis of ATRT and stained this section for INI1, and you can see that there is a total loss of INI1 expression within the tumor. INI1 is a nuclear stain, and only the endothelial cells are staining positive, which serve as the internal control. So we confirmed the diagnosis of ATRT, which is a CNS WHO grade 4. Now, ATRT are tumors which occur in very young children. They're very aggressive tumors. They can occur anywhere in the neuraxis, but most often they're in the cerebellum, in the CP angle. Histomorphologically, they have varied patterns as we saw in our case, and they exhibit a polyphenotypic immunoprofile. More than 90% show SMARCB1 mutation on chromosome 22, 11.2 locus, and the IHC surrogate being the INI1 loss of expression, which was seen in our case, and less than 5% show SMARCA4 mutation at chromosome 19p13, that IHC surrogate being the BRIG1 loss of expression. But what we know about ATRT now is it's not a single tumor type. Recent DNA methylation and gene expression profiling studies have identified 3 epigenetic subgroups of ATRT: the ATRT-TYR, the ATRT-SHH, and the ATRT-MYC. ATRT-TYRs are tumors that occur in infants below the age of 12 months. They're mainly infratentorial and they show overexpression of the melanosomal genes. ATRT-SHH occur in the toddlers between 2 and 5 years. They're mainly supratentorial and they show overexpression of the genes in the SHH signaling pathway. And ATRT-MYC are tumors that occur in children over 3 years of age, anywhere in the neuraxis, and they show overexpression of the MYC and the Hox cluster gene. And if you look at their methylation status, whilst the TYR and the SHH subgroups show global hypermethylation, the MYC group shows a global hypomethylation, and all of them show SMARCB1 mutations of different types. And these 3 are now included as the subtypes of ATRT in WHO CNS file. Other markers are also being studied for diagnostic and prognostic significance in ATRT. And this is our recent study where we have shown overexpression of a very embryonal marker known as the MELK, or the maternal embryonal leucine zipper kinase, which was overexpressed in more than 85% of ATRTs. But what about the prognosis of these children? Overall, they have a dismal prognosis. And as per this Children's Oncology Group trial, high-dose chemotherapy and stem cell rescue was associated with 4-year event-free survival rate of only 37%. Although it was slightly higher in the ATRT-SHH tumors, indicating that probably these have a slightly better prognosis. But importantly, a significant immune cell infiltration has been reported in ATRT-MYC and the ATRT-TYR tumors, throwing open a potential for future therapy with immune checkpoint inhibitors for these tumors. The next is embryonal tumor with multi-layered rosettes. But before I talk about this, I just want to very briefly discuss the obsolete tumor entity, the CNS PNETs. Now, up to the 2007 classification, PNET was a umbrella term under which there were several histological variants, such as cerebral neuroblastoma, ganglioneuroblastoma, embryonal tumor with abundant neuropil and true rosettes of the etanter, the ependymoblastoma, as well as medulloepithelioma. In the 2016 classification, the term PNET was completely removed from the diagnostic lexicon because it caused serious confusion in clinical practice for many years by lumping all these tumors under one category of PNET. And subsequently, these 3 tumors, the etanter, ependymoblastoma, and medulloepithelioma, have been shown to harbor a common genetic alteration that is known as C19MC alteration, where there is amplification of fusion of the microRNA cluster on chromosome 19, and these were redesignated as embryonal tumor with multi-layered rosettes, C19MC altered in the 2016 classification. These tumors are very aggressive. They occur in very young children. Most often they're supratentorial in location. And the way we diagnose this is by the FISH technique, where we can demonstrate the C19MC amplification. But luckily for us, there is a IHC surrogate that is LIN28A. Now, so these ETMRs can have varied phenotypes, an etanter phenotype, abundant neuropil and true rosettes, or they can have a very primitive ependymoblastoma pattern or a medulloepithelioma pattern with this trabeculae and these papillae. But all of them will harbor the C19MC amplification and will be positive for LIN28A. What is LIN28A? It's a protein that binds specific to certain microRNAs, and it is expressed very highly in the embryonic stem cells. And a diffuse and strong immunoreactivity of LIN28 has been seen in ETMR tumors, but it is not specific for ETMR because it can also be positive in some of the gliomas, particularly pediatric type high-grade gliomas, ATRTs, as well as the germ cell tumors. Nevertheless, it's a good IHC tool to support the diagnosis. And this is our previous study where we have looked at the expression of LIN28 on a large number of CNS embryonal tumors. And whilst it was positive in 100% of these ETMRs, it was also positive in about 23% of ATRTs, although it was negative in the other tumors. So it is a sensitive marker, but not specific for ETMR. So in the 2016 classification, ETMR was designated as ETMR C19MC altered. But now in the 2021 classification, C19MC altered has been removed, and these tumors are designated only as ETMR. Because although the large majority of ETMRs are known to harbor the C19MC amplification, the smaller percentage are known to have other alterations, particularly the dicer1 mutations, which can be either germline or somatic. So in WHO CNS5, embryonal tumor with multi-layered rosette is defined as an embryonal neoplasm conforming to one of the three morphological patterns: an etanter pattern, ependymoblastoma pattern, or a medulloepithelioma pattern, but harboring the typical C19MC alteration or rarely the dicer1 mutation, and they are grade 4 tumors. There are 22 newly recognized tumor types in WHO CNS5, and this includes CNS neuroblast. 3 come under the CNS embryonal tumors, which includes CNS neuroblastoma, FOXR2 activated, CNS tumor with BCOR, internal tandem duplication, and the CRINET, which is a provisional tumor type. CNS neuroblastoma FOXR2 activated is an embryonal neoplasm that exhibits varying degree of neuroblastic neuronal differentiation, foci of ganglion cells, a neuropil-rich stroma, and has the activation of the transcription factor called as FOXR2. Now, the way this tumor was identified was by the DNA methylation profiling study that was carried out by Sturm and colleagues in the year 2016. Now, basically what these authors did was that they collected about 300 and odd tumors that were diagnosed as peanuts from different centers, and they conducted a DNA methylation profiling experiment on all these tumors. And following this, they saw that most of these tumors were resolving to known CNS tumor entities, not just the embryonal tumors, but several other tumors as well. But in this, they were able to identify 4 new molecular CNS tumor entities, which they termed as CNS neuroblastoma, FOXR2 activated, CNS Ewing sarcoma family tumor, that is CIC altered, CNS high-grade neuroepithelial tumor, MN1 altered, and high-grade neuroepithelial tumor that was BCOR altered. So FOXR2 activated neuroblastomas are usually in very young children, supratentorial. They can have these undifferentiated cells. They can have foci of differentiated neurocytic cells, a neuropil-like stroma, sometimes even ganglion cells. This is one of our cases, a 5-year-old child with a supratentorial tumor, and histologically we saw all these small undifferentiated cells. And when we immunostained this, we found that it was diffusely OLIG2 positive. And so initially we thought this was a pediatric type high-grade glioma, but it was negative for GFAP. Only the stellate or the reactive astrocytes are positive. Tumor cells are negative, but it was strongly positive for synaptophysin. So we made a provisional diagnosis of CNS neuroblastoma and sent it across to DKFZ for confirmation. Dr. Kappa was kind enough to carry out the DNA methylation profiling, and this was confirmed to be CNS neuroblastoma with FOXR2 activation. So methylation profiling is actually a useful tool, particularly for tumors that are unresolved on histology, IHC, or even the simple molecular test, and more so in the pediatric high-grade tumors. The next case of mine is a 4-year-old girl who presented with headache and right-sided weakness for about 3 months. And you can see that there is a very large left frontoparietal tumor almost coming from extraaxial, dipping down into parenchyma up to the ventricles. It is solid cystic and enhancing heterogeneously. Histologically, it was a very malignant tumor, very high mitosis, apoptosis, undifferentiated cells. But in focal areas, it had this ependymoma-like pattern, perivascular rosettes, and still other areas had a sarcomatous pattern. It was negative for all the markers, the glial markers, the ependymal markers, the neuronal markers, histone markers, all of them were negative. And it showed INI1 retained status. There was no loss of INI1. LIN28A was also negative. The only 2 markers that were positive were vimentin as well as CD56. Now, because of this histology as well as these 2 marker positivity, we stained the section for BCOR, and we found that there was a strong BCOR immunopositivity noted in all these tumor cell nuclei. Now, this was the other tumor that was identified by Sturm et al. In their DNA methylation profiling, high-grade neuroepithelial tumor with BCOR alteration. And with this knowledge, what we did was we carried out DNA methylation, we carried out DNA sequencing. And here you can see that there is internal tandem duplication happening in the exon 5 of the BCOR gene, and that confirms the diagnosis of CNS tumor with BCOR internal tandem duplication, which is now introduced in WHO CNS5. In fact, we had 4 tumors that were BCOR immunopositive, but only one showed internal tandem duplication, telling us that BCOR IHC is not really specific for this internal tandem duplication. BCOR ITD tumors occur in very young children. They can have varied morphologies as what we saw, but they're characterized by an in-frame internal tandem duplication of the X-linked gene called BCOR, which is a BCL6 co-repressor gene. In fact, this is a key tumor driving genetic event in some of the tumors like subtype of bone sarcoma, clear cell sarcoma of the kidney, primitive myxoid mesenchymal tumor of infancy, and other tumors. And till date, we do not know whether these tumors are actually neuroepithelial tumors or whether they are sarcomatous in origin. The last tumor type is CRINET, which is a provisional tumor type in WHO CNS5. Now, this is a non-rhabdoid embryonal tumor that has this cribriform pattern, but shows loss of INI1 similar to ATRT, and it occurs in the vicinity of the different ventricles in very young children. And with this, if you look at the DNA methylation profiling, on the DNA methylation profiling in this atlas, you can see how nicely all these other CNS embryonal tumors are clustering distinctly, with CRINET almost merging with this ATRT, telling us that this could be probably a subtype of this ATRT itself. So a very short note on the association of embryonal tumors with genetic tumor syndromes. We know that medulloblastoma is associated with several genetic tumor syndrome, the SHH with the Gorlin, the Leaf-Romani, the Wnt with the Turcot syndrome, as well as the group C with the Rubinstein-Taibi syndrome. Rhabdoid tumor predisposition syndrome occurs as a result of the germline mutation of the SMAR-CB1 or the SMAR-CA4 genes. And these children can have different tumors in different organs in the body that are mentioned over here. But among the CNS embryonal tumor, it is either ATRT or it is CRINET. So we've come a long way in the classification of the CNS embryonal tumors. Initially, it was histologically defined. And then we had the genetically defined and the histologically defined, as well as the NOWS entities in the 2016 classification. And this has become much simplified in the WHO CNS5, as I've already discussed. Now, with the advancements in technology and bioinformatic approaches, several new molecular subgroups have been identified. They are being identified now, and I'm sure that many of them will find their way into the next WHO classification. So with that, I'd like to end my lecture, and I'd like to acknowledge the faculty from the Department of Neuropathology and Neurosurgery at NIMHANS, all my students, PhD scholars, research assistants, have worked with me for a very long time, helped me to establish this neuro-oncology laboratory at NIMHANS, which is currently a state-of-the-art molecular diagnostic laboratory. With that, I'd like to thank you for your kind attention.